In my practice, I often see people that develop pain in their forefoot region. While this can be a neuroma, it can be arthritis, often it's what we call a crossover second toe deformity because the toe deforms or crosses over, and typically it involves just the second toe. When it starts, it may be a vague area of pain in the forefoot that is hard to isolate, and it takes time, both your time and my time, and it takes sometimes several exams in order to really pinpoint where the pain is coming from. In time, a severe hammer toe deformity may occur, as we see in this model, where the toe cocks up and deforms. In this x-ray, we also see a dislocated second toe that's associated with a severe crossover second toe. But that's not always the way that it takes place. Often when a patient comes to see us, they have vague pain, and they may have actually very little, if any, deformity. It's only with time that these deformities start to occur, as we see in these photographs with a very mild deformity, and then in this next photograph we see a more severe deformity, and then in this last photograph we see a very severe deformity with the toe crossing up and over the great toe. Early on, a patient may develop pain without any deformity, but as time passes, often the second toe will deviate up and over the great toe, and that's why we call it a crossover toe. One of the most difficult things for a patient to do is to isolate the area of pain in the forefoot. And that's because a foot is a long ways away from the hands, and it's inside a shoe and a sock. When a person first comes in the office and is seen for a crossover toe deformity, often they sense a very large area of pain in their forefoot. And it's our challenge to try to isolate that to a very small area of pain so we can make the correct diagnosis. What we try to do is, instead of isolating the pain to a broad area, is to think even like an ice pick, where it would be going from the top to the bottom. And what we want to do is have the patient isolate a small area of pain, and they'll often mark it on the top and on the bottom of the foot, so that when they come in the office, they've really honed it down to a specific area of pain. What occurs when a crossover toe develops in its early stages is often a rupture or an elongation of the ligament. Now, it may occur on the bottom of the toe, and we see in this drawing a simulated hammer toe deformity. Sometimes a rupture will occur on the side of the toe, as we see in this drawing, and when this occurs, often the toe will deviate in an inward direction towards the big toe, and then in time may cross up and over the great toe. In our practice, we see lots of injuries and sprains and strains, but the history that the typical patient gives when they come in with a crossover second toe is one of no injury at all. Insidious pain develops, and it's usually a vague aching that seems to be associated with walking and increased activities, and decreases when a person sits or rests. Again, it's really important that we isolate where this pain is coming from, because there are other causes. And sometimes I will suggest an injection into one area to see if we can temporarily erase the pain. If we inject a joint or we inject a nerve, and then have a patient go out for a couple of hours and go walking. And if we temporarily make their pain go away, or we cause an absence of the pain, we know we're in the right area. And often over 2 or 3 office visits, we'll do 2 or 3 different selective injections, and maybe only one of them will work, but that's the key to making the correct diagnosis. Physical examination is very important to determine the exact location of pain. So we may push and pull and probe in the forefoot in order to find the exact location of pain. There are many structures in here that are very close, and we have to find the exact location of pain. And often we will do a test called a drawer test. And what that is a test to determine if there is instability in the lesser toe. We'll grasp the toe in our hands and we will pull up and down to see if there is instability. Now let's look at this exam in an actual patient. A drawer test is performed, and with the toe held with the thumb and index finger, the toe is thrust up and down, which usually creates pain. Early on, when we're treating this problem, we may suggest a change in shoe wear. Another alternative is we will use a metatarsal pad that is carefully placed in the insole to pad the area just behind the metatarsal head. Early on, there are several treatments that we will try in order to decrease the deformity that occurs with a crossover toe. We can tape the second and third toes together, which we call buddy taping. And what we'll do is we'll actually anchor the second and third toes together with a circumferential piece of tape, which is worn during the daytime when a person is walking. Another taping technique, especially when the toe has started to deform, is place a piece of tape over the second toe and tape the toe to the bottom of the foot. It's important when we do this that often this tape will come loose, and thus we have to place another piece of tape around the foot in order to anchor the tape around the second toe. Another choice is a steroid injection, and while we don't do this very often, in the early stages we may inject the toe and then tape the toe to give it stability. Often that is coupled with a metatarsal pad and a soft shoe. While conservative treatment may help in the treatment of the early crossover second toe deformity, with time or with more severity in the deformity, surgery may be necessary. The amount of surgery really depends upon the severity of the deformity, but in general, most of this can be done as an outpatient with regional anesthesia. The nerves in the foot are put to sleep, and if you wish, you can certainly be more sedated. Sometimes the only surgery that's necessary is to release the tight tissue on the top and then the side of the toe, and then to reconstruct the ligament on the outside, either with a suture or, in this patient, we see the preoperative x-ray with the deformity of a crossover toe, and then following the placement of a small screw with a suture attached, we see a realignment of that toe. Sometimes more surgery is necessary, and a tendon transfer is necessary to realign the toe and to depress it from its hyperextended position. On the bottom of the foot we see the simulated tendon, and we've actually split it because we're going to pass half of the tendon on either half of the toe deep to the nerves and blood vessels. Now let's look at the top of the foot so that we can see the tendon transfer. Half of the tendon is brought up on either side of the toe and sutured to the top of the toe in order to bring it down into a normal position. Sometimes it's necessary when there is a severe deformity to cut the metatarsal bone, as we see in this model. When we do this, we actually shorten the metatarsal. As we can see, that will then leave an area that is prominent on the top of the metatarsal. In this second example, we can actually see the screws in place. We can see that the bone has been shortened and that the extra bone has been removed. I think it's helpful to actually see a patient case in order for you to identify with what happens here with a correction. Here's a photograph of a patient's foot that shows a crossover second toe deformity. And this is the preoperative x-ray that was taken at the same time. This is actually at the time of surgery, and you can still see an open incision, and this is the x-ray showing the correction. And here we are several years later. This is a photograph of the foot, and this x-ray demonstrates a very nice alignment of the second toe with a successful correction. Her pain has been eliminated and her toe has been realigned. So how do patients do with surgery? Well, sometimes we do very little surgery and are able to achieve a correction, and sometimes we have to do extensive surgery, and that all can make a difference in how one person recovers after surgery. We've looked at our results actually on two different occasions, looking at crossover second toe repairs in older people and in younger athletic individuals. And by and large, I would say that our good and excellent results vary from 70 to 90%. What kind of things can you expect? I think that often it's a very slow recovery, and the toe can be swollen, and there can be a fair amount of numbness that gradually subsides over the passage of time. What we have to realize is that what we're achieving here is we're trying to correct or to remedy the amount of pain that you have, and the trade-off is that you'll have some stiffness or loss of active motion of your toe. I think that's a good trade-off, though, if we can get rid of the pain that is causing the difficulty with walking. Are there risks involved? Well, certainly there are risks involved with surgery. There's always a risk of infection, but we give antibiotics to minimize that risk. There's a risk that a deformity may be recurrent, that it may come back. And certainly there is an element of stiffness that will be there when we're all done. Also, when we transfer a tendon, sometimes there's a dead feeling that there's numbness, but not complete numbness, for several months after surgery. This seems to improve with time, but it really takes quite a bit of time, and it requires your patience. What we've tried to describe to you is how we diagnose and how we treat a crossover second toe deformity. It's actually a fairly common problem, but it's a tough treatment, and it's a tough treatment for you to go through. And it requires your cooperation, and it requires my treatment, us working together in order to get the best result possible. Thank you.